Great. Lymph nodes. So show of hands, who is reading neck CTs for head and neck cancer? Okay, pay attention. Here we go. We're going to differentiate lymph node stations, anatomic landmarks, recognize features of lymph nodes that increase their malignant potential. And this is the thing where you guys, we get into a lot of, review of cancer of unknown origin. Patient's got a lymph node. We can't find anything on anywhere else in the neck. This was my question that we had earlier. I'll show this. I'm going to show you the answer here in a sec here. What was the least likely feature of a metastatic squamous cell carcinoma lymph node? So we'll get back to that. So how comfortable are people with lymph node stations? It's very important to sort of do this appropriately for your head and neck cancer people. Sometimes based on your plane of imaging, it can get a little confusing. And I'll show you a phrase that I use when it's sort of borderline between two stations. So just talking about cervical lymph nodes, they're palpable in 90% of children between 4 and 8. They're almost always reactive. Reactive lymph node features are they're tender, they can be mobile and soft. Once you start getting into hard lymph nodes is where you start thinking this could be very worrisome. And then up to 300 lymph nodes in the normal neck. Evaluating lymph nodes with concerning features on physical exam, that's the role of our imaging. Confirm a palpable lesion as being a lymph node, and survey the remainder of the head and neck for the extent of disease. That's sort of our role, right? So normal lymph nodes, there's always this talk about long axis, short axis stuff. What plane do I mention it in? Now, all those measurements were made without coronal reformats. Now you can see them on the coronal. I'm just going to say, measure to your heart's content, and there are measurements available out there. The bottom line of this talk, and I have a slide that says this, I'm going to say it now, and you'll see a slide later. Morphology is king, not size. Size can be whatever, and there can be enlarged lymph nodes, but we're going to talk about morphology of lymph nodes as being much more important. How many people have seen these 6 millimeter lymph nodes, 7 millimeter lymph nodes on their cancer scans that were hot on PET? The size ultimately doesn't even matter. You have this hyper-enhancing lymph node that end up 7 millimeters on your CT, and that's harboring malignancy. So morphology is going to be king here. We'll talk about some of that, the morphologic features, okay? So a couple things to keep in mind when you're talking about your lymph node stations: the hyoid bone and above, between the hyoid and the cricoid, and below the cricoid. So you can see here, it doesn't project as well for you guys. This is 1A, 1B, 2A, 2B. Between the hyoid and the cricoid, you're going to get your levels 3 anteriorly, 4 below the cricoid. 5 is divided between 5A and B, depending on the level of the cricoid, and I'll show you posterior to the sternocleidomastoid muscle. 6 are your medial lymph nodes, and 7, you can get into the anterior and superior mediastinum with those, okay? So these are the anatomic landmarks where you want to keep in mind the hyoid and the cricoid, especially, okay? We'll go through each of these just very briefly. Level 1A are in between. Do you guys know the muscles that are in between? Anterior belly of the digastrics, right? Those are 1A. Lateral to the anterior belly of digastric, anterior to the sternocleidomastoid. It goes to the posterior margin of the submandibular gland. 1B, that doesn't say 2B, that's level 1B. 2A, you're looking at sort of posterior to the submandibular gland, but anterior to the sternocleidomastoid. There's level 2A nodes, level 2B nodes. Level 3, as we talked about, are superior to the hyoid. And then level 4, below the hyoid, above the cricoid. Level 5, guys, they have to be posterior to the margin of the sternocleidomastoid to be considered level 5. Have to be posterior to that muscle. Anywhere inside that muscle, they're going to be level 2s again, okay? Have to be posterior to the sternocleidomastoid. You can see the cricoid above the cricoid there. And level 5B, we talked about being inferior to the cricoid. Medial to the carotid arteries are going to be level 6. And then level 7, we're sort of getting into the anterior mediastinum there for those lymph nodes, okay? Just keeping in mind, you can always look that up. It's all online, okay? So morphology is king, internal architecture. You want to see a very beautiful, normal fatty hilum with a reniform shape. Sometimes you can get fatty metaplasia. That's okay. You're seeing a nice fatty hilum there regardless, okay? So a nice fatty lymph node there. This is where you start getting worried. Central low density. Now you want to differentiate that from a fatty hilum, obviously, on your CT, but once you start seeing stuff like this, guys, where it's central low density on your lymph nodes, this is going to pique your interest now. Okay? Squamous cell carcinoma loves to be low density and cystic. Certainly certain infections do, and you have your differential for cystic lymphadenopathy. But once you start getting central low density, now we're really going to tease out the morphology. Okay, we started with central low density. Let's work our way out from there. Okay, that's what I tell my trainees. This is a cystic lymph node. Okay, let's differentiate this from this. Okay. This looks like there's some solid components here, maybe a lymph node that might have started solid, that started growing up and started getting necrotic in the middle of it. So we're noticing some septations in there. We're noting some nodularity in there, a large cystic lesion here. How does that differentiate from here? Well, now you're seeing some inflammatory change around this lymph node as well, which you're not necessarily seeing with this. I'm going to tell you a little bit about the fact that you can't separate this lymph node from the surrounding musculature is very different than inflammatory change in the fat. There's two distinctions you want to make here. Okay? This looks infectious to me. And this could be cancer also, but this looks more infectious to me. This looks like a necrotic metastatic lymph node that has invaded itself into the surrounding soft tissue, what we call extracapsular spread. I'm going to get into that in a second. But you want to start in the middle and work your way out. I see central low density. Is it complex? Is it nodular? Is it septated? Are my borders good? If my borders aren't good, what's happening to the surrounding soft tissue? You got to tease out the morphology very carefully with a routine. That routine starts central and it works its way out from these lymph nodes. Okay. So bacterial lymphadenopathy, guys, is almost group A staph. They present with periadenitis with surrounding inflammatory change. Okay. Suppurative lymphadenopathy versus retropharyngeal abscess. We had a little bit of a discussion on that earlier today. Retropharyngeal abscesses will enhance corresponding to the borders of the retropharyngeal space, that bow tie configuration that Dr. Kubal showed you. Okay. This is a suppurative lymph node treated with antibiotics. Okay, so you can see how that becomes clean around the edges now because it's been treated. Here we got a problem. Okay, let's start centrally and work our way out. We have a low density centrally lesion enhancing surroundings. It is almost inseparable from the surrounding musculature. That is bad. The surrounding fat, not too bad. And obviously they're going to present with infectious symptoms rather than a lump in their neck, right? But the fact that you cannot separate this is extracapsular spread. This plummets the prognosis of the patient. To have a cystic lymph node is one thing. That's about a 50% decrease in prognosis. Double that, if not more, for extracapsular spread. So when you're in head and neck tumor board and you tell a head and neck oncologist, by the way, I think there's extracapsular spread, the room is going to go, oh, that's too bad. One lymph node with extracapsular spread plummets the patient's prognosis. That's how important it is to try to tease this stuff out on your neck CTs, guys. Okay? So a single ipsilateral metastatic lymph node at the time of presentation reduces survival by 50%, guys. A single metastatic lymph node. Okay? Now, cystic lesion here, low centrally, some rim enhancement here. This is a metastatic lymph node from a base of tongue carcinoma that you see right here. Okay, so you're going to start looking for the primary. Okay, and I'm going to show you some standard places. Now, Dr. Curtin mentioned, seeing low T1 signal and high T2 signal on your MRIs. High T2 signal in a lymph node is suggestive of cystic lymphadenopathy. Okay, it's cystic centrally. That's going to be high signal on T2. So you can use your MR in that way too. Okay, so we talked about benign features. These are malignant features of adenopathy, right? They're hard, non-mobile, painless lymph nodes. They're going to be round, loss of fatty hilum that can be in lymph node aggregates. And some of the other features that you'll see, obviously lower ADC on your MRs too. Okay, so another very, very important point, guys. Oropharyngeal cancer has made a massive comeback in the head and neck cancer world. Massive comeback. So we used to say young patients with a cystic lymph node, it must be TB or it must be infection. It's probably a branchial cleft cyst or some kind of lymphatic malformation, as we saw earlier. Never, never exclude the fact that this could be P16 positive oropharyngeal cancer in patients under 40 years old. It has made a massive comeback. And by the way, more often than not, you will not see the primary. I'm talking oropharyngeal, predominantly tonsillar cancer. You will not see anything in the tonsil. You will just see a cystic lesion, and you must tell your clinicians, I cannot exclude the fact that this may be oropharyngeal cancer, a cystic lymph node from oropharyngeal cancer. You will not, say it again, you will not see the primary in the tonsil. More often than not, you won't. So there needs to be some exploration there, okay? Okay, what else can look like a cystic or suppurative lymph node? Well, see, these are some of the things that we talked about that you just, you can mention the fact that there could be an infected second branchial cleft cyst. Again, it's anterior to the sternocleidomastoid, fairly typical location. Would I call this that all day? I would definitely not say this is a slam dunk, okay? Lymphatic malformations, they like to be at the base of the neck. They like to sort of like insinuate between different tissue planes. More classically, they have fluid levels on your MRI, which I'm showing you here. Okay. Now, extracapsular spread. Look at these data, guys. 25% of lymph nodes 1 centimeter in greatest length, 40% of lymph nodes less than 2 centimeters, 50% of so the greater the size, the more propensity they're going to have for extracapsular spread. That prognosis plummets. Okay, terrible feature. Morphology is king. I see a lymph node now, it's partially calcified or has punctate calcifications in it. This is your differential diagnosis for punctate calcifications in lymph nodes. Okay, we like to blow these lymph nodes off as all mycobacterial infections or granulomatous disease. Definitely not. There's a long list of differential for partially calcified lymph nodes. Here's some examples. These are punctate calcifications in lymph nodes. You can see one right there, the open arrow. The other ones are just showing you the nodes. This alone, you must include papillary thyroid cancer in your differential. Papillary thyroid cancer loves punctate calcifications. The lymph nodes love punctate calcifications even. So do not blow this off as just TB or granulomatous disease. Papillary thyroid cancer lymph nodes will calcify, okay? This is a thyroglossal, I love this case. This is a thyroglossal ductal cyst that had papillary thyroid cancer. It had little punctate calcifications and harbored papillary thyroid cancer. So punctate calcifications, papillary thyroid is the most common thyroid cancer, okay? Again, most people die with it than from it, but still, it'd be nice to make that diagnosis, right? Classic case of TB adenitis here, punctate calcifications in the lymph node. We're a big amyloid shop at BMC. So we see amyloid all over the head and neck. We do follow-up scans for amyloid. All this is non-contrast. This is one of the few reasons at BMC we get non-contrasted CTs of the neck for follow-up amyloid, because we want to see these calcifications all over the soft tissue. And we're sort of staging people there. But these are amyloid calcifications in the lymph nodes. Okay, so which lymphadenopathy is least likely to calcify? Well, I just showed you some cases of these, and by the way, based on this, it's pre-treatment lymphoma. Post-treatment lymphoma likes to calcify, pre-treatment doesn't, okay? Bilateral stuff is usually viral. Okay, here's some of the culprits of viral lymphadenopathy that you can see here. Sort of the main players here. So these are typically bilateral, enlarged, homogeneously enhancing lymph nodes. A lot of people just blow these off as reactive lymph nodes in the head and neck, right? Very common to see this stuff, okay? They don't have that periadenitis, by the way, that TB likes to have, okay? Bulky, low-level, homogeneously enhancing lymphadenopathy. We see this in young patients all the time, right? Viral lymphadenopathy, this is a case of mono that we had, all these scattered lymph nodes and sort of homogeneously enhancing, mildly enlarged cervical lymph nodes, okay, bilateral. So Hodgkin's disease and non-Hodgkin's lymphoma, they're relatively indistinguishable on MR or CT. Big, homogeneously enhancing lymph nodes throughout the head. I mean, these are going to be large, right? If you have treated disease, then you'll get your calcifications. But again, I emphasize pre-treated lymphoma won't calcify. But these are sort of, the two entities are indistinguishable, but you're going to get these very large, homogeneously enhancing lymph nodes throughout the neck. Okay. Nasopharyngeal carcinoma, I mean, 80% of patients with NPC present with massive lymph nodes. And sometimes, you guys, the primary in the nasopharynx, you can't even see. It's so subtle. I mean, mind you, sometimes you can see a nasopharyngeal carcinoma, but if you have big lymph nodes, by the way, and you're not seeing a primary, NPC is part of your differential there, okay? The majority of patients will present with bulky lymphadenopathy with sometimes a small or even an occult primary, okay? Okay, so let's talk a little bit about unilateral lymphadenopathy. That was bilateral for viral. Okay, so which disease entity more commonly causes unilateral cervical lymphadenopathy? Epstein-Barr, CMV, TB, HIV, histo. So it's TB. Mycobacterial infections will more often be unilateral. So let's talk a little bit about TB lymph nodes now. So head and neck involvement account for 12 to 15% of extrapulmonary TB. It favors the posterior triangle, internal jugular nodes. It's often painless, unilateral. It can be bilateral, and it helps with anti-TB medications. Again, this is my differential for cystic lymphadenopathy always. They're large, matted appearance, irregular margins. The demographic should fit if you're suspicious about TB sometimes. Calcified, periadenitis, unilateral stuff. This was the case of TB adenitis I showed you a little bit earlier. Okay? If we switch to kids, what is the most common cause of subacute lymphadenitis in children? Sort of along the same lines, atypical mycobacterium. Now, most common non-TB mycobacterial infection under 5, again, single dominant central necrotic, peripherally enhancing mass. So when we see these big, matted, low-density masses in children, that's usually MAI. Okay, and I'm going to show you, this is kind of what we see with kids. Okay? Before I worked at BU, in fact, Will and I worked together at Tufts Medical Center, and we had the floating hospital for children, our children's hospital. It was not a case report to see this in our practice. We get a lot of kids there, and sometimes you get these necrotic masses in these kids, and we were diagnosing MAI a couple times a year on some of these kids that we had. Okay. This is where you start glazing over, I know. Okay. Once I say Kikuchi Fujimoto, people are like, okay, they just start checking their phones and, catching up on their day. But we do make this diagnosis. I'm going to show you. We have 2 or 3 cases a year at BMC of Kikuchi Fujimoto, which is fun, but I get it. Okay, so these are the other things, a few other entities here. Okay, Castleman's disease. Isolated cervical lymphadenopathy is more common. So this was, you could see, and sometimes, guys, you can notice that it is really asymmetric unilateral lymph nodes. That should pique your interest a little bit. That's just not, I'm going to blow that off. That's just sort of an interesting thing. These are very enlarged unilateral lymphadenopathy. There's a differential for that, right? So Castleman's may be one of those. Kikuchi Fujimoto, another one. Again, we have made this diagnosis. In large lymph nodes, they usually don't exceed 2.5. Focal non-enhancing area suggests necrosis. The demographic should fit, but again, unilateral enlarged lymph nodes. Unilaterally enlarged lymph nodes. There's a differential for that. I just showed you 2 cases of that, right? Castleman's and this diagnosis. And it's just so fun to say Kikuchi Fujimoto to people. So if you have that opportunity, do that. And the last one is Kimura's disease, okay, that we include. So this is another chronic inflammatory disorder, non-tender soft tissue mass frequently. So the differential here, guys, first of all, they have elevated IgE, but they get these masses, as you can see here, subcutaneous tissues, lymph nodes, and salivary glands. So if you look at our case here, you see stuff in the parotid glands here, okay? And this is an actual lesion in the subcutaneous tissue. So this was sort of path-proven Kimura's disease. So you see the lymph nodes, you see the parotid lesions here, and you actually do see the soft tissue lesions here. If you can put that together, that's great. Okay, so this is the sort of the last part of the talk because it's generally the most diagnostically challenging part of cervical lymph nodes. Now you have a lymph node or several lymph nodes that are enlarged and you cannot find a primary, okay? So it's usually squamous cell carcinoma, and these are almost always the occult sites. So I'm going to explain one thing to you. So oropharynx, whether it's the palatine tonsils, base of tongue, hypopharynx is usually the piriform sinus, and the nasopharynx. So this is what happens whether you know it or not. You have made the diagnosis of a lymph node. We can't find a primary. ENT is going to do what they call a DL biopsy. This is a direct laryngoscopy, okay? And biopsy. They take patients to the operating room, they intubate them, and they are going with their hands all through the head and neck. They're doing an exam that they clearly would not be able to do on a conscious patient. So they're doing a direct laryngoscopy, and now what they're doing is they're taking biopsies of certain regions because they know where occult cancer is harbored. These are the areas they are biopsying on those patients. The highest yield areas for primary of unknown origin. So they're taking biopsies of the tonsils, tongue base, piriform sinus, nasopharynx, and they're going to try to find what's going on. Okay? So when you make the diagnosis of an enlarged lymph node and you can't find a primary, if they're going down the path of primary of unknown origin, this is what's happening behind the scenes to find that cancer, because these are the highest yield areas, okay? Now, are P16 positive? What does that mean to you? Where is P16 positive cancer harbored? Almost exclusively in the tonsils now, okay? So here's the thing, and I'm going to get into this in a couple slides. If you biopsy that lymph node, you're sending it for 2 labs, P16 and EBV. If it's P16 positive, it was tonsillar cancer all day. If it's EBV positive, where's the primary? Nasopharynx for nasopharyngeal carcinoma. They are sending that lymph node for those 2 labs, P16 positivity and EBV. Okay, so now they're getting a sense of where that primary was just from the lymph node. Okay, so this is the workup, guys. And you know, the FNA or core, they're sending it for these 2 things, and then they're going to probably stage with PET. But these are the 2 most important labs that they're sending that biopsy of the lymph node for. Okay? And remember, this is tonsillar, this is nasopharyngeal. Okay? So how can we help find the primary? You can consider the primary site and the distribution and the morphology. So lots of papers. Not going to go through this with you, but there's a predicted drainage pattern for certain types of cancers, right? So you can imagine like some of the oral cavity cancers, and up here, they're going to drain to these lymph nodes first and make their way down. Some of the other cancers down here are going to drain to these lymph nodes first and make their way up, okay? But there are plenty of papers, level 2, 3, 5A, you're looking at oropharyngeal cancers, hypopharyngeal and nasopharynx, right? So 2, 3, and 5A, you can imagine are coming from this site in your head and neck. 4 and 5B down here, they're coming from the hypopharynx, the thyroid, the supraglottic area, and the cervical esophagus. So the anatomy that lives low drains to low. The anatomy that lives high drains to high. So when we talked about the lymph nodes and the stations that they're at, you kind of know where to look for a little bit. I have a 2A, I'm going to focus my energies up high. If I have a 5B, I'm going to focus my energies a little bit down low. Okay? So most common cancer for unknown primary is oropharyngeal cancer. Lymph nodes are usually bilateral because of the crisscross lymphatics. And again, that's the lymph node drainage. Here's just a chart on what we just talked about, on the potential primary site for these lymph nodes. Okay? That's all online. So again, guys, morphology is king. Is it cystic? Is it necrotic? Is it calcified? Morphologic of metastatic lymph nodes, you know, the spherical shape, central necrosis, cystic change, abnormal cluster. If there's cystic change, think P16 positive oropharyngeal cancer. Papillary thyroid cancer can be cystic because of the accumulation of colloid. Now, homogeneous attenuation, think nasopharyngeal carcinoma. Again, these are going to be EBV related, large matted lymph nodes. Okay? Calcified lymph nodes, think of your thyroid cancers for calcified lymph nodes. Okay? And they have cystic changes, and then, you know, we talked about the differential there. Hypervascular lymph nodes, papillary can be hypervascular. What is the least likely feature of a metastatic squamous cell carcinoma lymph node? I'll probably say here that it's reniform shape. Okay? So there's your checklist. Again, you guys, I want you to start centrally and slowly work your way out with each lymph node. Be methodical about it. Think about this lymph node station that it's at and think about where the primary could be. If you can't find a primary, now it's primary of unknown origin. You're going to send it for EBB. You're going to send it for P16. Okay? What I was mentioning before, if you have a lymph node based on the plane of your imaging that looks like it could be level 2 or level 3, the phrase we use is junction level 2, level 3. Junction level 3, level 4. That's okay to say. They'll figure it out in the OR. But if it's like, oh, I don't know, it's sort of like I see this muscle and I don't know whether it is, it's okay to use that phrase, junction 2, 3 lymph node. Okay? And again, morphology is king. So I'll end it there. I think we covered all these objectives. So thanks.